Audio Jungle.
Hello, my name's Penny Tuffin. I'm an Advanced Practice Pharmacist in Palliative Care, and today we're going to be talking about the management of dyspnea in palliative care. What is dyspnea? It's frequently called breathlessness, and so I might use those terms interchangeably during the presentation. But dyspnea is a subjective experience of people being unable to get their breath, so having difficult breath or having laboured breathing or just having really uncomfortable breathing. And there can be many sensations involved in that. There can be the feeling that they just can't get enough air, so air hunger. They can feel like it's taking more of an effort to breathe. They can feel their chest is very tight. They may be breathing rapidly to try and compensate for that. They can't necessarily exhale completely, and so they've got that breathiness in their speech. And they may just feel like they're suffocating. So all in all, it's a very uncomfortable and unpleasant symptom for people to experience. There can be many different factors associated with dyspnea, and they can include psychological factors where people in particular may have a lot of anxiety. There can also be social factors dependent upon where they live, whether there's people smoking in the environment that they're living in. And so lots of different things can affect how a person feels their breathing's going, but anxiety tends to be a big component. Dyspnea definitely decreases someone's quality of life, and particularly as they're reaching the end of their life, this can be something that impedes their activity and stops them being able to spend valuable time with their family and friends. It's also a very distressing symptom for family and friends to observe, to be watching somebody who can't get their breath, who can't speak in full sentences because they're out of breath, can be very, very upsetting. Families can often have feelings of helplessness. They can pick up on the anxiety of the patient and actually be reflecting that as well, and feel quite panicked at times when the patient's breathlessness is worse. It's a really important influence on a person's quality of life. As I said, it can mean that they are then completely housebound or even confined to just one room because they can't move for more than 5 metres without becoming really breathless. It's very common that when people have breathlessness, that medical professionals may feel they need to sedate the person because the overwhelming distress being caused by the symptom is such that the person can't actually cope with being more alert. And these people and their families often feel socially isolated simply because they can't get out and about. They can't even engage in long conversations with people because they become so out of breath. Breathlessness is a really common symptom across all the advanced diseases that we see on a regular basis, and the range in prevalence can be quite different across different areas. So for instance, in cancer, different studies will report that breathlessness occurs in between 10 and 70% of patients. And as we look at this table, we can see that that rate is common across a lot of advanced organ disease as well. And it makes sense when we think about end-stage lung disease, so COPD, congestive obstructive pulmonary disease, where the rate is obviously very high. But in heart disease and renal disease, we see the same symptoms. And even in motor neurone disease and dementia, the rate of breathlessness is very high. We also know that as patients get closer to death and get to the last days of life, the prevalence and the severity of dyspnea can increase. It makes sense that if a person's breathing is impaired, that their survival will be shortened. And this is particularly true in terminally ill cancer patients. Breathlessness can be a sign of decreased prognosis. Generally, once people have severe breathlessness, we know that their survival is likely to be less than 30 days. So it is definitely a sign that can tell us that disease is progressing more rapidly. Dyspnea is a subjective sensation. It's not something that will generally be able to be measured, and so therefore we need to actually listen to the description that the patient's giving and the distress we can see in the patient in trying to get their breath. Physical examination and laboratory results may be normal. They may have good oxygen saturation levels, but still may feel very out of breath. So it can occur without any physical signs at all. As I've already mentioned, there can be lots of other factors that are influencing breathlessness, and we need to try and find out what those are and try and help patients with mediating the influencing factors so that we can have the breathlessness not such a severe impediment to their life. And when people are breathless, it also reflects back the other way, and their behaviour can become much more difficult. They can become very irritable and quite depressed because of their or have a low mood because of the influence breathlessness is having on their sense of well-being. So assessment is very important to help us understand how the person feels about their breathlessness and to work out strategies that are going to help manage it. We need to look at the history of how long the dyspnea has been going on, how severe it is, and what the quality is like. So using some of those descriptive terms that we used earlier. We want to undertake a complete medical and mental health history to try and work out what other factors may be influencing the person's dyspnea. A physical examination is of course important. We may be able to determine whether the patient has a chest infection, which depending upon their stage of disease, we may want to give them antibiotics to treat that and therefore decrease the dyspnea. We need to look at the functional impact that the dyspnea is having on the person. This will not only help us having some understanding of how it's affecting their quality of life, but it also gives us the opportunity to involve occupational or physiotherapists to help them with their mobility, help them with aids that may make their life easier, and to provide some sort of support for them physically. A psychological review of the impact and the distress that dyspnea is causing is also important. We can therefore support them psychologically and provide therapy that may support them and their family with strategies to help, particularly if they are having panic attacks when they're having an episode of severe breathlessness. We need to review the medications that they're taking and the treatments that we're using to determine whether any of these are influencing their breathlessness and making them worse, but also to determine if there may be therapies that we can use to improve their breathlessness. We also need to consider the prognosis of the person's disease. This will influence the treatments and therapies that we may introduce at this stage. The first principle of our management is to address reversible causes. This addressing reversible causes will depend, of course, on the prognosis of the patient and whether it is worth undertaking a whole lot of investigations and putting a person through that when in fact the improvement in their symptom relief and the improvement in their quality of life may be minimal. But there's a whole lot of things that will be influencing breathlessness, such as anemia, whether they have a pulmonary emboli, other obstructive causes, for instance, their tumour growing, exacerbation of their underlying pulmonary disease, if they have congestive obstructive pulmonary disease, an infection or irritation may be making that more severe. An exacerbation of cardiac failure, we may actually want to increase, for instance, their diuretics to try and help with breathlessness. They may have a pleural or pericardial infusion that we may actually consider draining to improve their relief from breathlessness. And of course, ascites may be the same. It may be worth draining that. We need to address anxiety or panic disorders. We're using generally psychologists to help them learn some good, and physiotherapists as well, to learn some good breathing techniques and ways to manage when they feel their anxiety levels increasing. And as already mentioned, we need to provide some functional support as well. So the non-pharmacological management process will involve a whole lot of supportive measures. These include providing reassurance and psychological support, reassurance that they're not going to die gasping for breath, and that we can actually provide some comfort measures for them. Providing relaxation techniques, as I mentioned, can be very valuable, and breathing techniques such as pursed lip breathing can be very, very helpful in teaching them to manage particularly the episodes of severe breathlessness. Positioning can be very valuable. Having people sitting upright, sleeping in a more upright position can help, particularly so that they get some sleep at night so they're not feeling so fatigued during the day, which will influence and make their breathing seem harder. Modification of activity levels and discussing this with them is very important. We want to make sure that they are using the time that they can get up and move around for things that improve their quality of life. So learning how to structure their physical activities during the day in a way that's manageable and not exhausting them, so they can't undertake physical enjoyable activities. So things like mobility aids will be very useful in that. A calm environment is also very useful. We want people to feel relaxed. We want them to be able to breathe as deeply as possible. And we know that by having a lot of fresh air ventilating through is very useful. So having windows open, having a fan blowing on their face will be very useful, and also being able to spend time outside. We automatically assume that oxygen therapy is what we reach for when someone can't breathe. However, for dyspnea associated with advanced disease, what we find is that the oxygen saturation does not necessarily correlate with the sensation of dyspnea. While oxygen is a standard therapy, if our oxygen saturation is low, it won't necessarily help somebody when their oxygen saturations are at normal level. So there's a lot of mixed evidence around the use of oxygen in palliative care, and generally what we find is that for some people oxygen therapy may help with their symptomatic feeling of dyspnea, and so therefore we may use oxygen particularly if they're trying to undertake activities, so that they have a feeling of being better. So generally a trial of oxygen is what we'll recommend for people. Some people find it advantageous, whereas other people it makes no difference. And it's really important if we're going to be using oxygen to discuss the safety issues around that. And for people who are smoking or have smokers in the house, then oxygen therapy is obviously not an option. When we're considering then looking at pharmacological management, the first medication that we will reach for are opioids. There's good evidence to show that opioids will relieve the symptom and the sensation of breathlessness. We can use those medications either orally or subcutaneously. There's no evidence to support using opioids in a nebulized formulation. So opioids relieve the sensation of dyspnea. They also are slightly anxiolytic, and so that is going to be a benefit for these people as well. We know also that small dose of opioid will not have a detrimental effect on people with advanced disease, and so we are quite confident in using small dose of opioids, titrating these to a person's needs to help with the sensation of dyspnea. We also know that dyspnea is more severe in people who have pain, so treating pain is really important. Of course, opioids play a large part in treating pain. The other medications that we might consider are benzodiazepines, and that's for their anxiolytic effect. Dyspnea is very strongly associated with feeling anxious and even having panic attacks. And so dyspnea will respond, or the anxiety associated with dyspnea will respond to a benzodiazepine. And so we will add this onto morphine if we feel that anxiety is a significant portion of the person's sensation. Suggested doses are very low. We might use lorazepam at just a very small dose, 0.5 per milligram. We can use it sublingually to have a faster effect, and we might use that up to twice a day. The other benzodiazepine that can be useful is midazolam. It has a very short duration of effect, but also has a very quick onset of effect, and so therefore small doses may be useful to relieve somebody's anxiety. So in summary, dyspnea is a subjective sensation. We can't measure it. We need to do a good assessment and find out the history and find out the influencing factors. We need to recognise that it's very frightening for patients and for families, and therefore provide a lot of support and reassurance and explanation about what's going on. We know that using non-pharmacological measures is very, very important, but if that isn't sufficient, then opioids are a good medication to add on in small doses. Thank you for watching this video today.
Audio Jungle. Jungle. Audio Jungle.